For more medical podcasts, visit us at podlearn.org.
Hello, my name is Dr. Richard Wardle, and in this presentation I shall be outlining celiac disease. So, if we look at the plan, initially we'll discuss the pathophysiology and try and link that to its clinical presentation. We'll also discuss important differential diagnosis, investigation of celiac disease, management, and important complications. The presentation will end with some EMQ tips and mnemonics and a short summary of what we've said. Throughout the presentation, the important facts to remember are coloured in red. So first, let's start with the pathophysiology. Celiac disease is caused by a T-cell mediated autoimmune reaction, and this affects the small intestine. Gluten-containing grains, such as those found in wheat, barley and rye, cause the autoimmune reaction, and this leads to villous atrophy and malabsorption in the small intestine. It's associated strongly with HLA-DQ2 in up to 95% of cases. The rest are HLA-DQ8. It's also associated with other autoimmune disease and the blistering skin condition dermatitis herpetiformis. So if we have a look under the microscope, on the left you see a normal healthy mucosa of a small intestine. The villi projecting out, increasing the surface area and adaptation for optimal absorption. On the right, following chronic celiac disease, you can see a number of changes. In your exams, the changes should be described as an intraepithelial lymphocytosis, crypt hyperplasia, which is evident between the villi, and an overall villous atrophy, thus resulting in vastly reduced surface area for absorption and therefore malabsorption. So the clinical presentation. The important facts to remember are these. Celiac disease can affect any age of person. The most common presentation is that of diarrhea and weight loss, for the reasons mentioned previously being malabsorption. It's also a very important differential when considering causes of iron deficiency anemia. So you just need to keep it on your radar if presented with a case of iron deficiency anemia. Other features of its presentation may be steatorrhea, abdominal pain, bloating, nausea and vomiting, aphthous ulcers, and in children it can be an important cause of failure to thrive or faltering growth. These features are all quite non-specific, so just remember what we said at the start: diarrhea, weight loss and anemia. These are the important things to keep in your head. In terms of differential diagnosis, again down to the non-specific nature of its presentation, it must be excluded in any patient with suspected IBS, because this can also present with very non-specific features. This presentation is similar to that of lactose and other food intolerances, and also that of inflammatory bowel disease, especially Crohn's disease, where patients can present with malabsorption. Investigation is very important in celiac disease, and it's very important that it's understood correctly. This is taken from NICE 2009 guidelines. It's important to inform people that any testing for celiac disease is accurate only if the person continues to follow a gluten-containing diet during the diagnostic process, i.e. the person must continue to take food containing gluten whilst they're being investigated for celiac disease. If they stop, this can cause a false negative. The first choice test is an IgA tissue transglutaminase. If this result is equivocal, then you can also use an IgA endomysial antibody test. If both tests are negative, and you still suspect that this person may have celiac disease, they may actually have an IgA deficiency. So you can also perform tests for IgA deficiency if the serology is negative. And if it is a confirmed case of IgA deficiency, you can use IgG tissue transglutaminase or IgG endomysial antibodies. Following a positive blood result, you need to confirm your diagnosis. To do this, you need a tissue biopsy, so you need to make a gastroenterology referral, and the gastroenterologist can take a tissue biopsy, the small bowel, and looking for those features that we mentioned earlier, an intraepithelial lymphocytosis, crypt hyperplasia, and villus atrophy. So the management of celiac disease is very simple. Patients must follow a lifelong gluten-free diet. This is proven not only to relieve the symptoms, but also to prevent potential complications, which we'll mention soon. Gluten-free products, so you can get bread, you can get pasta, biscuits, they're all prescribable on the NHS, and patients will commonly go to their local pharmacy to collect the products. Important complications to bear in mind. So in patients with long-standing untreated celiac disease, they may develop osteoporosis or malignancy. The strongest links are with gastrointestinal malignancy or lymphoma. Tips. The most important tip is that it's an important differential for iron deficiency anemia, and now is as good a time as any just to quickly revise iron deficiency anemia. The common causes being blood loss, such as menorrhagia or in GI bleeding, poor diet in babies and children, malabsorption in celiac disease, and in the tropics, hookworm can cause iron deficiency anemia. That's probably not one that you need to remember. Now is as good a time as any to sit down and revise the signs, tests and treatments of iron deficiency anemia, because they always come up in exams. If you struggle to remember which foods contain gluten, this mnemonic may help. BB worm. So barley, buckwheat, wheat, oats, rye and malt all contain gluten and should be avoided. So in summary, celiac disease is a T-cell mediated autoimmune disease affecting the small intestine. The resulting autoimmune reaction can be seen on microscopy as an intraepithelial lymphocytosis, crypt hyperplasia and villus atrophy. Celiac disease can affect patients at any age, and the most important presentation that you should look out for is that of diarrhea and weight loss. And don't forget anemia. When investigating celiac disease, the first choice test is an IgA tissue transglutaminase. IgA endomysial antibodies can also be used if the result is equivocal. Biopsy is required to confirm or exclude celiac disease. Management was simple, it's a lifelong gluten-free diet. Complications: osteoporosis and malignancy. And the malignancies were gastrointestinal malignancy and lymphoma. Thank you very much for listening. These are the references that I've used, It's a good idea to have a read over these if you have time, and good luck. Thank you.